Hello and welcome to our next video in our series of fireside chats about sleep telemedicine. I'm Dr. Barry Fields from the AASM's Telemedicine Presidential Committee, and I'm excited to join our other committee members again as we continue our series. So our last two chats covered lots of topics about sleep telemedicine implementation in kind of a question and answer format. Now we'll be presenting more fireside chats in a case-based format. We're looking forward to bringing some cases to life from the AASM's Sleep Telemedicine Implementation Guide, which, by the way, is a freely available resource on the AASM website that's actually just undergone some brand new revisions. So it's going to be really interesting to check out and use a little bit today. But before we get started on our case, I want to have everyone introduce themselves to you. So our first participant, Dr. Innessa Donskoy.
Hi, I'm Innessa Donskoy. I'm a pediatric sleep medicine physician at Advocate Children's Hospital in Chicagoland, Illinois, and I'm happy to be here.
Thank you, Dr. Donskoy. Next up is Mr. Dennis Kelley.
Hi, I'm Dennis Kelley. I am an advanced practice nurse. I work out of the Lewis Stokes Cleveland VA, part of the Northeast Ohio Veterans Healthcare System, and glad to be here.
Go VA, thanks. Next up is Dr. Marty Martin.
Hello, Dr. Marty Martin, also from Chicago, and teach at DePaul University, and also practice as a clinical psychologist specializing in behavioral sleep medicine.
Thank you very much. Another Chicago person. Let's head to Phoenix, Dr. Matthew Troester.
Hi, I'm Matt Troester. I'm one of the sleep and epilepsy neurologists at Barrow Neurological Institute at Phoenix Children's Hospital, and I'm pleased to join you today.
Great, thanks so much. And we'll head back up north, Dr. Christine Wan.
Hi, I'm Dr. Christine Wan. I'm an adult sleep provider with a background in pulmonary and critical care medicine at Yale University School of Medicine.
Great, thank you. And I'll thank everyone at the end, but I will say up front, thank you all for joining me for this video today. And once again, I'm Dr. Barry Fields. I'm a sleep physician at the Atlanta VA Healthcare System here in Decatur, Georgia, and I direct our sleep telemedicine program here. Okay, so let's get started. I'll be guiding us through case number 6 in the AASM's Sleep Telemedicine Implementation Guide. And I'll stop and ask for input from my colleagues all along the way. You as the viewers may want to stop at this point and have the guide in front of you and then restart the video if you would find that helpful. It's either the original version or the new version coming out. It's still case number 6, and that way you can follow along. Otherwise, if you want to continue listening, you'll hear the audio with or without the guide in front of you. So you should be seeing our first slide. So this is a fireside chat about hypersomnolence and regulated prescriptions, again, in the sleep telemedicine implementation guide. So I'm going to start the case. So Miss W is a 22-year-old college student. She sees a board-certified sleep medicine physician, or BCSMP, I'll say physician, in Alabama, where her family resides. But most of the year, she actually lives in Virginia, where she attends college. She complains of excessive daytime sleepiness and often finds it hard to maintain wakefulness in class. These symptoms started in high school, but she attributed them to sleep deprivation at that time. Now she finds that even with 8 hours of sleep per night, she finds it hard to stay awake throughout the day and frequently gets complaints about falling asleep at her study groups. So my first question is going to be for Dr. Donskoy. So how would you approach this scenario, particularly if Miss W was a younger teen away at a boarding school? How would you maybe approach it differently?
And of course, it's such a shame she didn't present earlier, as the symptoms had been going on for so long. That's a fantastic question. It's really 2 questions in one. One side of that question is, how can we implement telemedicine with minors or with dependents or with people who are having help with their medical decision making, their legal guardians? What do we do if we need to do a telemedicine encounter and they're in a different location than that caregiver or parent, we'll say in this case? So the ideal, of course, is to have every telemedicine encounter look like a in-person face-to-face encounter with the patient and their parent present at the same time. That really means that if we're trying to do a telemedicine encounter, a lot of planning needs to be put in place on the front end, at the registration end, to make sure that the parent and the patient will both be able to access that visit. Whether that means getting a secure Zoom link, whether that means both will have a login to access whatever app is being used by that healthcare system, they should both have a way to enter that visit. Ideally, especially for an initial consult, this is really what insurers sort of request of visits, that both the patient and parent be present. Now, for follow-up visits, there can be exceptions made. And at times, if let's say a parent only will be present, the visit can still go on and perhaps be billed through a time and care coordination pathway. Of course, that leaves out the patient and any input they had on how things have been going and the plan moving forward, which is less than ideal, but sometimes a possibility. There are some insurers that might be open to a similar sort of coverage for an initial consult as well, built on time and care coordination, but that definitely needs to be sort of looked into prior to the visit and to make sure the patient isn't going to get charged, really needs to be kind of solidly planned out on the front end. The other side of that question is, what do we do when care needs to cross state lines? So whether it's a minor who's under 18 or someone over 18, but let's say on parental insurance, which many adolescents are staying on until mid-20s. What do we do when a provider is in one state, but the patient is in another? So again, a lot of work comes in with the registration team and the care planning team. What really needs to be looked at is what kind of coverage the patient has. Certain insurers will allow for exceptions for telemedicine that crosses state lines, even for an initial consult. So if that's the case for this patient's insurance, there shouldn't be an issue moving forward. Now, if they have a coverage that necessitates the patient physically reside in and be present in a certain state during the visit, and that provider has licensure in that state, that's where we come upon an issue. And we may discuss it later on as we go through the case, but there are ways to expedite the licensure process if you know your patient will physically be in a different state during the visit. The Interstate Medical Licensure Compact is one great resource that can allow for a little bit more of a speedy way to get licensing in a state to see a patient who will physically be there during the visit. But again, that takes time. And so it's important that we know this on the front end, let the patient and the parent know that there's going to be a little bit of legwork done before their visit so that they're open to the possibility that it might get delayed as we wait for everything to fall into place. And you know, in reality, even if the visit gets covered, it's really important to remember that that doesn't necessarily mean anything we order at that visit will be covered. So there are certain requirements set in place, especially for things like ambulatory monitoring, home sleep testing, that does require the interpreting physician to be physically in the same state as the test is being run. So just because a visit will get covered doesn't necessarily mean testing will. And that will need to be kind of confirmed as testing is planned and as that moves forward.
Great. Yeah. Well, it strikes me that one of the themes that we've discussed previously in these fireside chats is do your homework. And we think
Yeah.
about kids doing their homework, but we have to do our homework also with ourselves and with our staff to ensure that we do the work up front so we have some sense of what may or may not be covered. And certainly we don't want to get ourselves in trouble down the road without having all of that information. So those are really great points. Okay, so Ms. W often feels better after 15-minute naps and sometimes dreams during short naps. A multiple sleep latency test, or MSLT, performed after a normal overnight polysomnogram recording 8 hours of sleep reveals a mean sleep latency of only 2.3 minutes and 2 out of 5 sleep onset rapid eye movement periods, or SOREMs. The physician makes the diagnosis of narcolepsy. So I'm going to move on here to our next question, and this one is for Mr. Dennis Kelley. So now that Ms. W has her narcolepsy diagnosis, how can we assess the AASM quality measures for narcolepsy through telemedicine? Is it even possible? And I threw up there the title of the paper that described those quality measures.
Well, I think that's an excellent question. I think when we look at quality measures, I don't think that as providers, we necessarily think of them as quality measures. We kind of view them more as just good practice and doing the right thing. So I thought I would take a minute or two today to kind of review the paper with you and kind of what some of the quality measures are, and then see how they fit into telemedicine. Because as you look at the citation here, you see that the article was published in 2015 in the Journal of Clinical Sleep Medicine. And this was probably a little before we started really doing telemedicine, or particularly started doing telemedicine, given the pandemic and the limitations that we have in person-to-person meetings. So I thought I would kind of just take a look at these and come up with them. So there are 7 processes that the group came up with for 3 major objectives. And really the first process is kind of having the ability to assess sleepiness. And certainly this is doable through a telemedicine because we use our sleep questionnaires such as the Epworth and Stanford and Karolinska Sleepiness Scale, as well as the Cleveland Adolescent Sleepiness Questionnaire and some visual analog scales. And those are all very doable by telemedicine. We can kind of be able to do that. And then you come into the process, the second process, which is really looking at treatment initiation following diagnosis. And keep in mind that these processes that they come up with aren't necessarily linear, but are things that you'll want to do to ensure quality with this. And so they say that you want to be able to initiate treatment within a month, and hopefully we should be able to do that by setting up telemedicine or in-person visits to do this. And it may be medication, or it may be behavioral things, be able to look at different things such as, using modafinil or armodafinil, or using Xywav or Xyrem ideas, as well as using, some things for the treatment of cataplexy or hypnagogic hallucinations, SSRIs, tricyclics, those kinds of things. And again, we can monitor and start those through telemedicine, which would kind of help us meet that first objective, which is just to kind of reduce the daytime sleepiness and be able to look at it. So far, I think we're pretty good with being able to use telemedicine, and there don't seem to be any real limitations as a result of this. When you go to look on for another process, you want to look at comprehensive sleep history and physical examination. And I think that this is the area where telemedicine may be a little bit wanting. And we know that not just for narcolepsy, but for other sleep diagnoses and other telemedicine processes, that it's difficult to do a physical exam. In some cases, if you're doing telemedicine from one clinic to another clinic, such as the way that we sometimes do in the VA where we're using our remote clinics, it is possible to do an exam because you can have an exam cart and you can have exam apps that will allow you to do this. But for probably video telemedicine for the patient to home visits through a smartphone or laptop or tablet, it probably was going to be very, very much wanting. You might be able to do some very simple physical examinations, such as looking at, facial cranial structures, etc., but more in-depth types of things, such as the types of neurologic exams that you'd want to do to be able to rule out other causes of sleepiness. That's not going to be very well done or very well possible through the use of telemedicine. If you want to do an objective assessment of sleepiness, that of course is possible to do that, and that would be just being able to review PSG and MSLT results, making sure that they're done, being able to report those results out to the patient, discuss those ideas with them. Those are certainly doable through telemedicine, as well as just, simple subjective and objective ideas to have the patients report out to you. Are they feeling better? Are they feeling sleepy? What types of symptoms may they have going along with these things? Any ideas of drowsy driving or those kinds of ideas to go along with this, which then takes us up into the idea of, treatment follow-up and being able to look at how things are going, how the patients are doing. And ideally, in the past, we always did those with a person-to-person visit so that you could see the patient, examine the patient, discuss it with you. But I think those things are also doable through telemedicine, as you can talk to the patient and see them and kind of figure out how they're doing and kind of be able to do that. And it would be quite doable. And then I think you want to look at documentation issues, which again are doable through telemedicine. You want to be able to look at, what types of treatment do you have the patient on? If they're on medications, have you documented any side effects or drug-drug interactions? Perhaps if you have patients that are of childbearing age, you'd want to be able to discuss the armodafinil and modafinil effects on hormonal birth control. You want to be able to make sure that your patients were aware of that and could practice some other ideas. That's doable through telemedicine. And finally, the last idea with this is the idea of safety measures. And they're very important. I think it's a safety measure to be able to let the patient know what's going on, to be able to address the idea of driving and drowsy driving, the idea of looking at household tasks such as ironing and doing other things, work situations where you may be dealing with hazardous materials, or being, difficulty with falling asleep inappropriately. That's all be able to do this and do this. So overall, I think we can fairly well meet the quality guidelines and goals set forth in the quality measures paper, with the exception of the physical exam piece. And that, as we all kind of recognize, is pretty much a limitation across the scope for telemedicine. But overall, I was impressed that this paper, having been done a number of years ago, is so well written and so well adept at addressing all of the needs for narcoleptic patients that even in an age of telemedicine, for the most part, we can meet those objectives. So again, kudos to the task force that did this. They did a great job.
I agree with you there. And it also, when you were speaking, I was thinking how I usually will say telemedicine is special, but it's not that special. In other words, most of the quality measures that you discussed lend themselves very easily to telemedicine. You made a great point. Of course, physical exam, there are always those elements that are a little different, but telemedicine is a tool. It's not a whole new way of providing care. So many of the quality measures do apply, and you did a great description of that. So you also kind of led into the next topic, which is treatment. So the physician has made the diagnosis and prescribes modafinil, which is effectively improving the patient's wakefulness without side effects. So given that that's the case, let's move on to Dr. Troester. So she is now on modafinil. She's not having side effects. Modafinil is a Schedule IV controlled substance. What special considerations exist for interstate prescribing, and how would they differ if you prescribed a Schedule II or a Schedule III medication?
So these are great questions, Barry. So the telemedicine counter, for whatever reason, really seems to be a sticking point when it comes to this controlled substances business. And the questions really that get raised are whether or not the examiner has adequate information of the patient's health status based off of this, kind of virtual encounter. And do you have confirmation that the patient is accurately representing himself or herself? And so, the DEA, as we all know, is the federal agency responsible for the enforcement of the Controlled Substance Act. And I'll get to that in a second. But in 2008, there was something called the Ryan-Haight Act, and that added to the Controlled Substances Act this notion that you can't get a prescription through the internet unless it's quote unquote valid. And to be valid, it has to be issued for a legitimate medical purpose, and there has to be at least one medical evaluation that's conducted. And with foresight or prescience, the group that created this legislation added a segment for telemedicine. And so pre-pandemic, most of the telehealth issues about controlled substances dealt with medication-assisted therapy. And the exceptions that existed in that had to do with the opioid endemic that we've all been dealing with. What the Controlled Substances Act provides really is that unless there is some applicable exception, DEA regulations require a practitioner to obtain a separate DEA registration in each state in which she or he dispenses a controlled substance. So just like in this case, this provider, if he wanted to continue to provide, modafinil to this young lady, would have had to have got a DEA registration in Virginia in addition to the one he already had in his primary state. So as a sleep provider, there's several controlled medications we use. And the controlled substance, whether it's Schedule 2 or 3 or 4 or 5, doesn't matter. They're all subject to the same Controlled Substances Act. So the Schedule 1, those medications don't really have any accepted medical use, but Schedule 2, those which have a high potential for abuse, those are things that we use a lot. Those are the traditional stimulants like amphetamines and methylphenidate. Schedule 3, which has a little bit less potential for abuse than 1 or 2, that's things like gamma hydroxybutyrate, or we tend to refer to as Xyrem. And Schedule 4 is most of our hypnotic medications, and then some of the newer wake-promoting agents like solriamfetol, or like in this case, modafinil or armodafinil. Schedule 5 stuff really have a low potential for abuse, and really those are probably just going to be some of the newer anticonvulsants which we might use to treat like a REM behavior disorder. However, there's lots of unscheduled medications we could use if we need to, including newer ones like pitolisant or Wakix, atomoxetine, or what we also know as Strattera, and then amantadine and clindamycin, some other wake-promoting type medications that we might use along the way. But the laws apply the same, whether it's Schedule 2 or 4, to get to Barry's question. But the one thing I'll just point out before I kind of turn it back to Barry is that on January 31st of 2020, the Secretary of Health and Human Services declared a public health emergency with regard to COVID-19. And as part of this, no longer, for right now, during the duration of this pandemic or this public health emergency, you don't need to have a separate DEA license to prescribe a controlled substance in another state.
Yeah, lots in flux right now. You bring up a great point, and I always stress to people, it's important right now to know what the facts are and know what the rules are, but also know that they're changeable. Now we're in a pandemic early in 2021. Hopefully, as folks are listening to this, maybe later this year or next, this is in the rear view mirror, but the thought process that Dr. Troester brings up, I think, is really important for all of us to think about. These are the questions we need to be asking, no matter what the rule is at that point in time. And Matt, thank you so much for going through that as you did. That was extremely helpful. I'm going to actually move on to a group question. So now kind of thinking about this case as a whole before I kind of move on to the last section of the case. For the group, are there elements of this case that lend themselves better to telemedicine rather than to in-person care? Any benefits to telemedicine here? Thoughts?
Well, the first that comes to mind, of course, is that she's a young woman already struggling with keeping up with schoolwork and keeping up with everything she needs to do. So to have her take time to physically travel to see a sleep doctor, which we don't know how close they might be, versus at the click of potentially on her phone, be able to access a visit, is going to save her a tremendous amount of time and probably stress, knowing that she's stepping away from responsibilities that, potentially already she's sort of lapsing and performing. And to get at, Dennis Kelley's prior point too, That's an impressive MSLT. She's a very, very sleepy young woman. I don't want her behind the wheel. I don't. I want her safe at her location, logging in, knowing she's not a drowsy driver, and keeping herself safe. So I think those two aspects already make us quite fortunate to have the ability to do this with telemedicine.
I also think that one of the benefits of telemedicine to this case on both the provider side and the patient side is I think you can keep a lot closer tabs on the patient. I think you can follow up. If she can, get a hold of you, particularly as a young adult, they're so facile in using electronic devices and smartphone and that. If she feels that she can contact you if she has any questions or concerns, or you can easily get in touch with her, I think it lends itself to closer follow-up and perhaps better overall outcome.
Absolutely. Yeah, I think telemedicine is just a wonderful tool here that I just hope even post-pandemic, the field is made so we can use it, that there are not so many restrictions that in cases like this, we can't, because we can show that we can use it and we can use it really well. So those are all great points. Any other quick points anybody wants to make, or else I'll move on? Okay. So let's keep going. So the patient plans to continue telemedicine follow-up, returning to see the physician in Alabama through telemedicine. And that physician verifies Virginia's medical and pharmacy board requirements, as well as their state policy regarding interstate prescribing. The physician obtains a medical license in Virginia and registers into Virginia's Prescription Drug Monitoring Program, or PDMP, to continue to prescribe this medication to the patient. With each new prescription, the physician checks the state's PDMP to ensure proper patient use. So I'll stop there and ask Dr. Martin, how does interstate medical licensure work? What is this interstate medical licensure compact that Dr. Donskoy mentioned a little bit earlier? And then I'll ask anybody if people have their own experiences. I don't personally, but I wanted to see if anybody else has experience with this IMLC.
Yep. So what it is it is an agreement that is made state by state and territory by territory. So what it enables you to do is, I'm licensed in the state of Illinois. So then they actually have a website that you can go to, and it's color coded. So if I'm dark blue, I look for another dark blue. So by applying to this, I'm able to be licensed in another state. But first, what has to happen is typically the state legislatures, they may have to make agreements about which other states they will grant the license towards. So what's happened is this is evolving over time, and more states are entering into the compact. And clearly what's also happened is with COVID-19, it's accelerated it as well, because it used to be prior to that, maybe telehealth was optional. Now it's a little bit less than optional. It really is the way that people can actually practice. So that's the way that it works. But one of the things you really want to make sure of is this. So let's imagine I'm licensed to use the case in the state of Alabama, but the student is in Virginia. But let's say it's spring break, and unbeknownst to me, the student goes to Florida or goes to North Carolina. So you always want to ask the question is, where are you kind of physically, geographically? Because I may not be licensed in the state of North Carolina. So it's always important to find out is, where is that particular patient at the time of the visit. The other thing is this you have to watch out for as well. So maybe I'm on vacation, I go to Alaska. So although I was initially licensed in another state, does that apply? So you really have to be very mindful of, where is the patient physically located? Where are you physically located? Where do I have licensees to practice through the Interstate Medical Licensure Compact? Now, if, for example, you want to practice in a state that's not part of the compact, then you can apply for a temporary license. So the temporary licenses can be restricted for a certain amount of days or a certain number of patients. Each state kind of does its own thing, if you will. Now, within psychology, which is what I practice, they have a similar thing called the PsyPact. So I have had experience with that. So you have to apply for what they call an e-passport, and then you submit some additional credentials and it gets verified, and then you up for the PSI-PACT, and you have to renew that. So it's a number of hoops that you have to do, but it's very similar to kind of a credentialing process with a little bit more documentation. So those are some things you need to consider.
I usually tell people that if your state is part of this compact and you want to be licensed in another state on the compact, it's going to save you time if you use the compact. Not going to save you money though, because you have to pay the fee for using the compact service, and then you still have to pay the licensing fee in the other state. So it's not to save money, but it's to save a lot of the time and the paperwork.
And that's a great point. And what's just come up is a colleague of mine received notice from California because they have a license in California, but they reside in Illinois, wanting to find out how much income they earned in the state of California, tax them on it, because states need revenue. So you really want to make sure you do your own documentation about money earned, in a particular state, because states are cash strapped and they may want to collect some income tax. So it's kind of a new wrinkle.
I would not have thought of that, but I am not surprised. Unless anybody had anything else quick, I'm going to just keep on moving here. All right, so I'll keep on going with the case, and this is getting toward the end of the case now. So because of the side effects of modafinil, the patient is switched to an amphetamine derivative for hypersomnolence. In order for the physician to e-prescribe amphetamine derivatives, however, specific software compliant with electronic prescription of controlled substances, or EPICS, is needed. The Drug Enforcement Administration, or DEA, legalized EPICS in 2010, with the last state, Vermont, legalizing it locally in 2011. After the appropriate software is selected, verification of physician identity occurs through a third-party authentication service that often requires detailed personal information, including credit reports. So Dr. Christine Wan, the last set of questions is for you. Do you have any experience with EPICS? Can you tell us anything more about it? And if not, or anyone else have any experience with EPICS, they can go right ahead too. So I'll open it up for Dr. Wan. And Dr. Wan, will have you unmute yourself. And
sorry.
That's okay.
So the EPICS came around largely in response to the opioid crisis. It basically provides a way of e-prescribing or electronic prescribing prescriptions that have traditionally been paper-based. And the whole goal of that is really to decrease the likelihood of drug abuse, or in the form of stolen prescriptions or forgery or doctor shopping. It was signed into law in 2018 as part of the Support Act, which is just a larger bill to address the opioid epidemic. It mandates electronic prescribing for controlled substances, and the deadline had been January 1st, 2021 to comply, but I believe CMS has delayed that to 2022 just because of the pandemic. It really is a process that requires several DEA requirements. The first is that the software has to be a two-factor authentication for the provider, and that has to come in two forms. So it must be either what the provider knows, so for example, password, what the provider has, so like a token or push notification through the phone, or what the provider is, like a biometric as in a fingerprint. We use the password and the push notifications in our healthcare system. The electronic health records must be certified for EPICS as well, and there needs to be a process for ID proofing the provider, and there also has to be detailed reporting about the whole process, including auditable items. The healthcare organization generally uses a third party to implement EPICS, or I've been calling it EPCS, but you've been calling it EPICS. So while the healthcare organization really does the research for which vendor they want to use and make sure their providers comply, it's really the vendor, the third-party vendor, that's responsible for the DEA compliance. All our pharmacies in Connecticut are also EPICS registered. They have a third-party audit that makes sure their software applications meet federal security requirements. We're also part of the Prescription Drug Monitor Program, which is a statewide database that really monitors our prescription practices as well as the patient behaviors. I get a monthly report for the PMP, our state PMP, that tells me what I'm prescribing, how much I'm prescribing, and compares me to other providers of my subspecialty, so I can really follow that. There are lots of benefits to Epics, electronic prescribing, with the obvious thing that it's directed to do, which is to decrease the risk of, fraudulent prescriptions, and also have an audible electronic trail. It also, allows you to prescribe right out of your electronic health record, which is really convenient. It minimizes patient wait times. It reduces unnecessary office visits, which is something we're dealing with currently. It also has a way of, alerting you to formularies or allergies that might be pertinent. I know it can be a burden for some practices. I'm part of a large healthcare organization, but for smaller practices, there are some technological hardships, and you can't apply for waiver, at least at this time. The Support Act also allows you to, in exceptional cases, waive the Epics requirements. So for example, if you have a patient who you feel like prescribing them the medication via electronically might delay their care and have serious health implications, you can, that can be a process of waiving the requirements for that.
Thanks so much, Dr. Wan. I learned a lot. I don't interface with Epics or EPCS. Maybe I made Epics up. I don't know. But so that was really educational for me. That's an area that I really am unfamiliar with, but it is so essentially important, especially as I think telemedicine to some extent is here to stay, and we do need to know about it. I'm going to finish reading the very last part of this case, and then I'll be posing this question to the group so everybody can kind of think about it as I finish up the case. So a limitation to e-prescribing Schedule II drugs is the acceptance by pharmacies, Dr. Wan mentioned, although much more common than in the past. Not all pharmacies accept Epics prescriptions or have EPCS certified software. Some physicians may find that even pharmacies with Epic's capabilities occasionally refuse to fill e-prescribed Schedule II medications. So it still can be kind of tough. So I will now pose this final group question to everyone. Not everyone needs to answer, but I just want to hear if there's anybody with any strong opinions. At what point would you discontinue telemedicine? In this case specifically, at what point might you as the provider back off and say, we need to discontinue telemedicine service at this point? I mean, I'll add and see if anybody else does. I would certainly add, we're now working with controlled substances in a young woman who is in a high-risk population of young adults. So if I was concerned that there was any kind of medication diversion going on, medication abuse going on, or concerns about her safety, if I'm prescribing Xywav or Xyrem, sodium oxybate, something like that, and she's in a dorm, if I feel that she's potentially socially unsafe with that kind of medication around without closer monitoring, I personally might at that time exercise my responsibility to work on finding her a board certified sleep physician in the area that she's in Virginia. Because at that point, I would say, I think somebody close by needs to be keeping closer tabs on what's going on. And if I saw some warning signs, something like that, it may be hard to get labs such as urine toxicology studies at a lab and get those results back to me quickly. And so if I started to run into those issues in that case, I would really ask her to link with an in-person physician, sleep certified physician in her area in Virginia. So for me, that would be a red line. And I don't know if anybody else has anything to add from the rest of the group.
I think going back to the quality measures, if something came up that seemed to indicate that we needed some type of physical exam or physical follow-up, then that certainly would be a reason to discontinue the telemedicine.
Right.
Another would be is if you have a temporary license, you have to make sure you monitor the number of days. So if you had it granted for 60 days, then legally you can't do anything on day 61. So just be mindful of the limit of days for a temporary license.
Any other feedback about discontinuing telemedicine? I think those are all valid points. And just like any other tool or treatment, we have to know when to start it, when to use it, but also when to potentially stop it if we feel that it's not in the patient's best interest anymore. All right, so some key points for Miss W's case, just to review. And these are also summarized in the case written up in our implementation guide. So we learned so many things. So these are just a few of the key points. So a medical license is typically required in the state where a drug prescription is being filled. Some states require PDMP registration to prescribe Schedule 2 through 4 medications. Finally, all states require EPICS or EPCS certified software for Schedule 2 substances. But some pharmacies still will not accept those prescriptions. So it can still be kind of dicey. A lot of this is a work in progress, as is our learning of sleep telemedicine, which we will soon continue. So I will stop there. That is case 6. We covered it all in the implementation guide. I want to thank so much everyone who joined me today for these interesting cases in this case discussion. I learned so much. And of course, I want to thank the AASM staff for making this Fireside Chat video series possible. They do a ton of work on it as well. And I hope that you all found it useful who are watching us. Next time, we will have another case for you from the AASM Sleep Telemedicine Implementation Guide. But which case will it be? Stay tuned to find out. Bye-bye.